Thank you, dear Kyriakos. First of all, I would like to thank the organizing committee and especially my friend, Professor Vasilis Kotis, for this invitation. And as you can see, my talk is about the way for treating patients with diabetes and obesity. Just a minute. Okay. So this is my disclosure. And in recent years, we see an alarming increase in diabetes and obesity as well. And among 650 million people with obesity, I cannot, there is a problem with...
Is everything okay?
Moment.
Well, it looks good on our side.
Okay. So among the 650 million people with obesity, around 30% have diabetes, and among 425 million with people with diabetes, around 90% have obesity. Obesity and diabetes seems to be endemic, and just to remind you that endemic means two or more epidemics that interact synergistically and contribute to excess disease burden in a population. And now the question is, what happens in this endemic of obesity and diabetes? Obesity promotes insulin resistance and beta cell decompensation, which are the main causes of diabetes. In addition, sleep disorders, the inability to be active, and the stigma and impaired mental health worsen the situation of diabetes, which in turn increases obesity through medication-induced weight gain, through neuropathy and decreased activity, through hypoglycemia and stimulation of food intake, and through the stigma and impaired mental health. Physical and environment and social environment add also synergistically in this way. I have a problem here. Okay. So many medical associations recognize obesity as a very serious disease and very complex disease, and 90% of health practitioners recognize obesity as a disease, compared to only 70% that they don't believe it. That's why they don't care about their obesity. Obesity is also related with many comorbidities, such as metabolic, between them are the cardiovascular diseases, stroke, dyslipidemia, hypertension, type 2 diabetes, mechanical comorbidities, and mental comorbidities as well. Many obese patients, people suffer from depression because of the high weight, the higher weight they have. It also has a major impact on life expectancy, and as you can see here, it decreases according to the increased BMI. Now the question is, how much weight loss is needed in order to prevent diabetes-related complications or to postpone diabetes-related complications? Evidence suggests weight loss of more than 10% may further improve some of the obesity-related complications. However, weight loss has dose-dependent and tissue-dependent biological effects, and the benefits increase according to the percentage of weight loss, as we can see here. The greater the weight loss, the more the benefits we have from this situation. So it's very important, as you understand, and very challenging to treat obesity and to treat diabetes as well. Now, the question is, if diabetes remits with 15% weight loss, what is our target? As I have already mentioned before, the greater the weight loss, the more the benefit. So we have to move to lose weight as lower as we can. This review, very interesting review, published some years ago, looks at diabetes and obesity as one condition called obesity and suggests that they should have combined treatment strategies. Now, to the question, how we treat a patient with type 2 diabetes and obesity, a patient 65 years old. According to the other NTSD consensus report, obesity is a very important and very health issue that we have to take into account. And for the first time, this consensus looks at diabetes as this serious problem, and we see an increase of almost 50% by 2030, and an increase of morbid obesity almost 25%. It's very, very high, this percentage. So the goals of diabetes care are, first of all, to prevent complications according to this consensus and to optimize quality of life. So preventing complications require glycemic control. On the other side, weight management has also a very critically and important aspect of disease, which in turn can help modify the risk factors, the cardiovascular risk factors, and also can help modifying glycemic management. So weight reduction excuse me. So weight reduction has mostly been as a strategy targeting glycemic management, and also we can reduce the risk for weight-related complications. As we have seen previously, a weight loss of almost 5 to 15% should be our primary target in management for many people having type 2 diabetes. However, a higher magnitude of weight loss, as we have seen previously, confers better outcomes and lead also to remission of diabetes. Additionally, weight loss can also improve the quality of life. So, for the achievement and maintenance of weight management, we said we should set individualized weight management goals, and we have to choose glucose-lowering therapies with high or very high dual glucose and weight efficacy according to the consensus of ADA and TSD. And among all the medications that now are available on the market, GLP-1 receptor agonists dominate the treatment of diabetes, not only for diabetes and obesity as well. Diabetes and obesity are considered to be twin epidemics of the 21st century, and probably we're living in a new era, in an era of targeting diabetes and obesity at the same time. As we know, both are complex health issues combining genetic, epigenetic, and lifestyle factors, including also socioeconomic and environmental impact. And as such, new scientific developments are advanced treatment approaches are needed. For the treatment of diabetes and obesity, nowadays a range of options is available. And in order to provide the most effective treatment, it is important to assess and communicate the risk of obesity to an individual, but in a manner they understand it. It is also vital to appreciate the barriers they face. And as we know, glycemic improvement and diabetes remission would be realistic goals, and people should be empowered to seek out such options when they are ready to do so. Here we see all the anti-obesity drugs that are now available on the market. Tirzepatide is now under consideration by FDA, but it has been approved for type 2 diabetes. All these drugs have a central site of action, and leptin and insulin inhibit ACT neurons and stimulate POM neurons, informing the hypothalamus about the energy status of the organism. Here we see that peripheral signals from the gut and adipose tissue influence hypothalamic pathways, and on the other side, brainstem pathways not only crosstalk with the hypothalamus, but also affect brain centers involved in hedonics, reward, and executive decision making. Now, let's have a look at the effects of a GLP-1 receptor agonist, because the drugs, they have been approved for diabetes and obesity as well. And here we see the size of the GLP-1 receptor expression within the nervous system, and on the right we see the beneficial effects of using GLP-1 receptor agonists. We have to keep in mind also that GLP-1 receptor agonists lead to augmented energy expenditure through favoring thermogenesis in brown adipose tissue. And it can be happened either through direct stimulation of brown adipose tissue, or indirectly through favoring release of FGF21 in the liver. And so we see an increase in energy expenditure and a decrease in body weight and glycemia as well. Here we see that there are the short and long-acting GLP-1 receptor agonists, and more or less all of them can lead to a body weight reduction, and they can also improve glycemia, as we can see here, measuring HbA1c levels. Now, liraglutide was the first GLP-1 receptor agonist studied for diabetes and obesity as well. And the SCALE program studied the effects of liraglutide under different conditions in obesity, in prediabetes, diabetes, in weight maintenance, and so many others. And it is shown that liraglutide at a dose of 3 milligrams as an adjunct to diet and exercise was associated with reduced body weight and improved metabolic control. And here we see a change also, a decrease also in HbA1c level, and also we see a decrease in insulin dose by those treating with basal insulin. We know that weight loss is difficult, but weight maintenance even more so. And the SCALE trial examined also the effect of liraglutide in maintenance, in weight maintenance, and we see that the participants not only could maintain the weight loss during the treatment period, but also during the follow-up period compared to placebo. This study also shows the role of exercise and the combination of exercise and a GLP-1 receptor agonist, in this case of liraglutide. And we see that combining exercise and liraglutide, we may have a greater reduction of body weight and also a great reduction in body fat percentage, which is very important for our patients. We don't like to lose muscle, but only body fat. Another GLP-1 approved for diabetes and obesity is also semaglutide. Semaglutide is a once-weekly injectable GLP-1 receptor agonist, and the SUSTAIN program studied also the effects of semaglutide as monotherapy or as add-on to other hyperglycemic drugs, also as add-on to insulin, and we see a great reduction in these dark blue columns of weight using semaglutide. Additionally, we see also an improvement in HbA1c level using semaglutide in two different doses, 0.5 milligram or 1 milligram. The STEP trial examined again semaglutide at a dose of 2.4 milligram, also under different conditions in those with or without diabetes, but with obesity or overweight. And we see in those without diabetes, we see a mean weight loss of almost 15%, and we see also that almost 86% of the participants achieved a weight loss of more than 5%, and almost 70% of the patients achieved a weight loss of more than 10%. And those having also type 2 diabetes, they could lose a weight loss of almost 9.6%, and 70% of the patients achieved a weight reduction of at least 5%, and almost 50% achieved a weight loss of more than 10%. We see also a reduction in HbA1c level, and a great proportion of the patients achieved an HbA1c below 70% and or below 7% and or below 6.5%. This is very important for our patients. The same results we see also using dulaglutide, another once weekly injectable GLP-1 receptor agonist, and we see a weight reduction using dulaglutide in different doses, 1.5, 3 milligram, or 4.5 milligram. And we see, in addition, also the beneficial effect of dulaglutide in patients with type 2 diabetes and obesity as well. We see also a change in HbA1c level, and this is very important. And the high percentage of patients achieved this good glycemic control using dulaglutide. Nowadays, novel and emerging medications for obesity are expected. And first of all, we expect for oral semaglutide. However, GLP-1 receptor agonists have very low bioavailability when administered orally due to poor absorption across the gastrointestinal epithelium and due to degradation by proteolytic enzymes. That's why it's co-formulated with an absorption enhancer snack, which is a small fatty acid derivative, and so it promotes absorption across the gastric epithelium and increases also bioavailability of oral administration. And the PIONEER program has shown also this beneficial effect of oral semaglutide as monotherapy or compared to other anti-hyperglycemic drugs that are now available on the market, and we see a great reduction of body weight in the dark columns using oral semaglutide. The introduction of GLP-1 agonists has increased the scientific interest in overall in incretins, and combining the body weight lowering and glucose lowering effects of GLP-1 with a more potent improvement of beta cell function through the additional GIP action could potentially offer a more effective treatment of diabetes and obesity, and studies suggest additive or even synergistic effects when combining GIP and GLP-1 for the treatment of obesity. So the first combination is this combination is tirzepatide. Tirzepatide is a combination of GIP and of GLP-1 and GIP, and they have central. They act centrally in hypothalamus and brainstem pathways, and they add we have additive and synergistic effects from this combination. This program studied the effects of tirzepatide in participants with overweight or obesity, but also in those with diabetes. And we see that the use of tirzepatide in 3 different doses, 5, 10, or 15 milligrams, we see an improvement in glycemic control, and we see also a great reduction of weight loss. But also in those without diabetes, we see a marked reduction of weight loss using tirzepatide, according to this trial program. And comparing tirzepatide to semaglutide once weekly, we see that this combination is more shows is more efficacy in terms of glucose control and body weight loss as well. Another very promising drug is cagrilintide. Cagrilintide is the human amylin analog, and just to remind you that amylin is a neuroendocrine peptide hormone and is co-secreted with insulin from beta cells in response to food intake. And it has also multifactorial effects, and as we can see here, it can regulate appetite and energy expenditure and increases also satiety. Amylin has also central sites of action as the GLP-1 receptor agonist. And we see data show that we have body weight decrease progressively according to the dose of the cagrilintide. A very good and promising medication is the combination of cagrilintide and semaglutide. They have also additive and synergistically effects. And as you can see here, either through the hypothalamic pathways or through the brainstem pathways. And this combination shows is more efficacy concerning weight loss and concerning side effects, nausea or vomiting, there is no difference. Clinical data show that this combination, cagrilintide and semaglutide, resulted in a significantly greater weight loss compared to semaglutide or to cagrilintide alone. And the mean change in HbA1c with this combination was greater compared to cagrilintide, but not compared to semaglutide. However, these were trials, phase 2 trials. Another very promising combination is a combination of GLP-1 and glucagon as well. And we see that results from different studies show that this triple combination may lead to an improvement and of weight loss, to a greater reduction of weight loss, and also to an improvement of glycemic control, much better than the double combination. As I have mentioned at the beginning, glucagon increases thermogenesis, and through this this mechanism can act also combined to the other ingredients. And the first data show that we have a progressively decrease in body weight and also in an improvement in glucose control using this triple combination. This review looks about the obesity management and asks if it is a primary treatment goal for diabetes and obesity, and if it is time to reframe the conversation. Actually, I think the time is right to consider the addition of medications targeting people with type 2 diabetes and obesity. Such a change in treatment goals would recognize, of course, obesity as a disease with reversible complications and require a shift in clinical care. And this approach would also address the pathophysiology of the disease process for type 2 diabetes, and could also recognize adipose tissue pathology as a key underlying driver of the continuum of obesity, type 2 diabetes, and cardiovascular disease as well, and reap metabolic benefits for far beyond the glycemia. Reaching to the end of my talk, I think that not only I, but there is evidence that in the next years we will see novel pharmacotherapies that could revolutionize the way we treat obesity, but the way we treat also the complications related with obesity, and also the way we treat cardiorenal and metabolic complications of obesity, including also diabetes and cardiometabolic and liver comorbidities. However, it remains to be seen whether precision medicine may offer personalized solutions to individuals with obesity and diabetes, and whether it may represent the future of medical weight management, along with the development of novel and very potent anti-obesity medications currently in the pipeline. And which is the central idea of precision medicine. It is to identify the right delivery system to achieve the right dose of the drug to the right place. So it's more individualized, the treatment procedure. For the time being, we use GLP-1 receptor agonists for type 2 diabetes and obesity. We're looking at using them for type 1 diabetes, pre-diabetes, and FLD and PCOS, and who knows in the future, maybe we can use them for many other diseases. But according to this, we have to keep in mind this Hippocrates famous quote, let food be thy medicine and medicine be thy food, because it's very important. And on the food and on the change of lifestyle, then we can add medications, oral or injectable medications. So taking all this into account, I think that now a new and charming care has begun for the treatment of diabetes and obesity. And with this, I would like to thank all of you for your attention. Thank you very much.